Greetings. My name is Stuart Sherman, and I am the Glenn A. Lehman Professor of Gastroenterology here at Indiana University School of Medicine. I serve as the Director of Advanced Endoscopy at IU School of Medicine. I'm here with my partner and colleague, Dr. Mark Gromski, who is Assistant Professor at Indiana University School of Medicine, who I work alongside with every day doing ERCP procedures. Today we will be discussing our recent publication in gastrointestinal endoscopy titled Technological Review, Developments in Innovative Duodenoscopes. Mark, those of us who are in the ERCP field have heard a lot about innovative duodenoscope design in the last few years. Could you provide us with a bit of background to help explain what has prompted this innovation?
Thanks, Stuart. I'd be happy to. The current burst of innovation is really centered around infection prevention. This is primarily in response to a number of well-publicized outbreaks of infections that were linked to duodenoscopes, and most of these outbreaks were about 5 to 6 years ago. But if you look back into the literature, there's actually some signal of some infection transmissibility risk dating back decades. In the past few years, the FDA had a number of safety communications which first requested post-marketing data from the reusable duodenoscopes and then eventually led to a forward-looking statement recommending adoption of innovative duodenoscopes with enhanced infection prevention components. I believe all of the above is what has led to the substantial investment in the research and development of the innovative duodenoscopes that we're seeing coming out today.
Currently, the innovative duodenoscope design can be divided into two types: reusable duodenoscopes with disposable tip components and single-use duodenoscopes. Mark, please review which devices are currently FDA approved for usage in the United States.
Sure. Currently, we have 6 innovative duodenoscopes approved by the FDA for use in the United States. As you mentioned, these can be separated into reusable scopes that have a distal end cap component that's disposable, or fully disposable duodenoscopes. Starting with the reusable scopes, all of the major manufacturers of traditional reusable duodenoscopes have an offering in this category. This includes Olympus, Pentax, and Fuji. All of them have a similar product where a reusable duodenoscope has a single-use cap at the very distal tip. And after each ERCP procedure, that distal cap is stripped and disposed of. And this is supposed to allow for better reprocessing around the elevator mechanism. In addition, Pentax has the ED34 I10T2 product, which actually has the elevator component within the disposable end cap. And so after each procedure, part of that elevator along with the end cap is disposed of. And then in the second category is the fully disposable or single-use duodenoscope, and both Ambu and Boston Scientific have a product in this category.
Thank you, Mark, for those insightful answers. Our paper reviews the studies in the literature currently evaluating these scopes. The available data are sparse, but is currently growing with time. The experience is still early with these innovative duodenoscopes. Mark, can you review the pros and cons of these duodenoscope categories? What are the things that gastroenterologists should know and institutions should consider?
Well, clearly the infection prevention issue is the main benefit of these innovative duodenoscopes. It's well known, as I mentioned, that there is some infection risk with standard duodenoscopes. Whether traditional or innovative reusable scopes are used, units reprocessing duodenoscopes need to be very careful and having highly trained scope cleaning technicians and creating a high responsibility culture for this group of people. We know that with high vigilance and utilizing enhanced reprocessing methods, the risk of contamination of reprocessed duodenoscopes can be quite low, and the risk of transmission of infection should be even lower. In essence, the single-use duodenoscopes offerings should eliminate the risk of infection transmission from duodenoscopes themselves. And the enhanced reusable duodenoscope should at least significantly improve the risk, if not eliminate it. Although infection transmission from a duodenoscope is a risk, it's a low-frequency, high-severity event. There are plenty of other risks to the ERCP procedures that need to be considered, including pancreatitis, perforation, infection, and bleeding.
The field of novel duodenoscopes has exploded in the last year or two. For the physician group or institution that is still not sure or how or whether to implement the novel duodenoscope designs, can you share some of the aspects that should be considered?
You're right. The innovation really has been intense, and so intense that the thought process around whether or which innovative duodenoscope can be quite confusing. First things first, the status quo of a center doing the same thing that they did 20 years ago to clean duodenoscopes probably isn't acceptable. Even without the adoption of any innovative duodenoscope today, anyone doing ERCP should have a team that ensures high-level reprocessing. This includes not only training but retaining scope cleaning technicians, periodic audits of the quality of that work, and likely a surveillance program to measure the quality of the reprocessing and to detect any early warning signs within that system. Infection prevention clearly needs to be a priority for any center that performs ERCP. But back to your question, with regard to adoption of these innovative duodenoscopes, really decisions are variable based on the institution or physician group considering it. One size, I don't believe, fits all for this. Decisions should be based on what provides the best care for your patients in your particular situation. Things to be considered include the volume of ERCPs at your center, the experience and the volume of ERCPs by the physicians, each individual physician doing ERCPs, cost of the innovative duodenoscope and cost of bringing them on board, and potential environmental effects. It's a very complex calculus to consider all of these simultaneously, and it varies by institution. Although single-use duodenoscopes will continue to iterate over the coming years, we don't believe that the single-use offerings perform quite at the very high level technically as the traditional reusable duodenoscopes. However, we do believe that there is a role in these single-use duodenoscopes. Thus, we advocate for single-use duodenoscopes in a subset of cases that may be higher risk from an infection prevention standpoint.
Thank you, Mark. At Indiana University, we have rolled out our limited usage of single-use duodenoscopes based upon a tiered risk evaluation of the specific patient and case of ERCP being done. Can you outline our thought process and tiered approach for the viewers?
Sure. So at IU, we came up with a three-tiered approach, and we had input from a number of different parties to come up with this. And it's a Tier 1, Tier 2, Tier 3 approach, where in Tier 1 we recommend actually that the endoscopist use a single-use duodenoscope. These are patients that may put our fleet of scopes at significant risk of becoming infected, and so they may have a history of CRE, they may have a history of multi-drug resistant bacteria on bile cultures, or a history of recurrent cholangitis and recurrent instrumentation. The second group, Tier 2, is a group where we leave it to the discretion of the endoscopist to make their own decision on whether they think it would be best to use a single-use duodenoscope or a reusable duodenoscope. And in this group, it includes patients that if they came in contact with a contaminated duodenoscope may not do as well fighting that infection. So that includes patients who are on immune suppressive medications, patients who may have cancer and are on chemotherapy, or some other immune suppression such as bone marrow transplant. And then our third tier, which is actually the largest group of patients, is all the other cases. And in those ERCPs, we actually recommend reusable duodenoscopes.
That's great, Mark. Thank you for that answer. I think this will help others who may not follow the space as closely to consider how to implement these technologies into their own centers. Can you look into the crystal ball, Mark, and tell us where we'll be with these novel duodenoscopes in 5 to 10 years from now?
Well, it's always hard to look into the future, but I think the number one need right now are more data in regards to these new scopes. They're new offerings, and there's not a lot of experience yet. And so a couple questions are, number one, how well do the reusable duodenoscopes with the single-use components decrease the transmission risk of infection? Number 2, how well do the single-use offerings perform on all of the different span of ERCPs that we do? And then in addition to those data are cost analysis data and cost effectiveness tools for us to use at the institution level. And finally, environmental impact is very interesting to a number of people. Finally, I think that the entrance of the single-use duodenoscope into the GI space is a very interesting development, and it will decrease the time of the development cycle. And so it'll be shorter period of time to prototypes and shorter period of time to reaching the market in the clinical space. And I think this will allow for improved iterations, improved quality, and we may even be seeing some innovations that we haven't even thought of yet in this space.
It is certainly a fascinating time to be an ERCP. That is all we have time for today. I'd like to thank Dr. Gromski for his insightful answers to my questions today.
Thanks, Dr. Sherman.